There is one question I do have to ask the two of you, and it's when will you choose when you choose one KRAS targeted therapy? What is your thought process to choose that KRAS targeted therapy versus sotorasib versus adagrasib, or considering a clinical trial that includes the combination of chemo, immunotherapy, and a KRAS inhibitor?
So in most of the trials looking at the sort of an immunotherapy inclusive approach is in the frontline setting. And so I think that it's a discussion with patients. And I think one of the things in my own practice is if I have a patient who has a PD-L1 of 95% and a high tumor mutation burden, and they have a KRAS G12C mutation, that may be somebody where I say, well, it's possible that the KRAS inhibitor is going to have some efficacy, but there's maybe some risk that I have to stop a medicine that I anticipate being quite efficacious, and maybe I'm not that excited about putting that patient on study. On the other hand, if I have someone with PD-L1 of 5%, moderate tumor mutation burden, my level of confidence of efficacy of sort of the standard frontline therapy is not as good. Recognizing the biases of being at an academic center and running clinical trials, that's someone where I am excited about looking at clinical trials to improve on the standard of care.
I think NRG is something that we're all learning about. When you find an NRG fusion in your patients, how does that affect your treatment plan subsequently for first and second line therapy?
Right. So I think in the first line setting, the easy answer, which in my practice would I think still be where I find myself, is that the approval for the agent is in patients who were previously treated. So the approval technically is not in the frontline setting. In my own practice, I would be inclined to sort of go with standard, therapy, and whether or not to include immunotherapy probably depends on the full profile of the NGS testing from my perspective. Although in saying that, whether my interpretation of it is right or not, I don't know, but it might affect what other mutations I see as to whether or not I include immunotherapy. But certainly I would use this agent in patients who have been previously treated. You're not going to get a duration of response of nearly a year for docetaxel, and I would be enthusiastic in that setting.
I do have a follow-up tricky question for you. So we know that NRG fusions are less than 1%. So we have a patient that had a biopsy and have DNA NGS, and all tissue have been exhausted. Is this fusion something that you will go seeking after for a second biopsy?
I think that's an excellent question, and I would describe this as being very context specific. So if I have an 82-year-old with 120 pack year smoking history where I've exhausted all of the tissue, I'm not necessarily looking to do a new tissue biopsy in that setting. On the other hand, if I have a 36-year-old woman where we never looked for RNA as part of their workup previously, that person is somebody who I really am going to want to biopsy. And I think that's one of the things that is very different in an academic practice. I think that's one where, right or wrong, we tend to assume that we're going to find something. Sometimes we don't. But so I think it does matter a lot on what your pretest probability of an actual mutation would be.
All right, so I do have a question about c-Met, because I'm seeing in practice that c-Met is being tested at the time of progression. In your practice, David, are you testing at diagnosis or at progression, and which sample?
That's a good question, and I didn't really discuss that, but I clearly tested first line because in a patient with untreated disease and a MET exon 14 skipping mutation, that's a validated target to use for first line. But I didn't discuss that MET is also very frequently a bypass pathway that's acquired by other tumors with other driver mutations. And so pretty frequently with the EGFR mutant tumor patient, they will progress on osimertinib, and we will find MET amplification upon repeat biopsy. So Clearly, with the driver mutant tumors, we do repeat biopsies in virtually everyone, and it's a real thing. Combining, if you find a patient like that and you use OC plus tepotinib or capmatinib, you have a very substantial and durable second response that you can achieve in these patients. So the answer to your question is both. But now that we have an available therapy, I think it's really important for us to do MET-IHC, especially in second-line plus patients, because we now have a therapy that we can use to target it. So in our institution, we have our NGS or our molecular panel called POMAL, and we have two options when we order it. It's POMAL alone or POMAL plus MET and HER2 IHC. And there's parentheses there in the order set that says for second line only. And so we should especially test it upon progression. And then the online question?
Yes. So what is the schedule of, I think it's not fully spelled here, but what is the schedule of cenocotuzumab?
That's an NRG question.
Yeah.
Do you want to answer that, Dr. Guerin?
So it's yeah. What I must admit, the schedule. Do you know the schedule?
No, I don't know the schedule, NRG1 therapy. But we can figure it out and get back to you at the end of the program.
Yeah, for all the 50 patients you've treated with NRG
Exactly.
fusions?
I had treated 0. Yes, so I do have a question for you. Do you have a preferred ROS1 agent for first-line therapy, or the ones that are currently approved?
Yeah, probably taletrectinib.
Is it that driven by the CNS adverse events, or that improved progression-free survival that's reaching the 45
Little bit,
months?
it's just the point estimates are maybe a little better, but both Repo and Tally are very equivalent.
And
most
my
ways.
last question on ROS1, is there any role for sequencing of these agents? Like start with taletrectinib, and then eventually when cytisidenib gets approved, go up to that one?
Well, that's a good question. I think, sure, if you start with entrectinib, the data are that these newer generation drugs are active. You know, switching from one to the other, I don't know if there's good data, but there's probably a pretty low activity. So I'm not sure about that.
Yeah, I think we have a lot of upfront for ROS1, but we still, I think, lack subsequent therapies. Thank you so much.
Also looking for bypass mechanisms on progression, like we talked about before.
Yeah, I tend to do IHC HER2. Sometimes some of these
Right.
patients you find some of this. But thank you so much, Dr. Carbone. We are going to go back to the question that was online, and that is for the schedule of cenocotuzumab, as we're all learning about this agent, and a fusion that's less than 1%.
Yeah, it comes up at 2 weeks, but was the frequency.
So it's every 2 weeks. The first infusion is 4 hours, and if the patient tolerates it, I think it can be shortened to 2 hours. And we all learned something, the entire panel, about the frequency and the dosing. I think RNA sequencing is essential for diagnosis. We're talking about rare fusions like NRG1, but for ROS1, MET exon 14. And on the personal level, my mom was rebiopsied because the initial assay was only DNA. They ran out of tissue. So it is worth the rebiopsy to do RNA sequencing. You may find very good targets, very good options for treatment in these patients. Try to convince your Latino mom to get another biopsy. That was a challenge.